Thank you, Roger, for inviting me to give this talk last night. And thank you for the organizers. And I'm not gonna be talking about drugs. It's gonna be about lifestyle. And we're not worried much about drug side effects here. But this understudied, very important segment of the population that's rapidly expanding, and we don't know what the best approach is. So we know that obesity is a major national and international health problem, and we just had one drug approved by the FDA yesterday. The prevalence of obesity is increasing across all age groups, including obese older adults, which we define as persons 65 years old with a BMI of 30 and more. But the appropriate clinical approach remains controversial because of the decreasing relative health risks associated with increasing body mass index in the older age group. And importantly, there's major concern that weight loss therapy would have potentially harmful effects in this population. And it's very relevant for our symposium because you can't have fat loss alone when you do weight loss. You also lose muscle and you also lose bone. Are you exacerbating normal age-related sarcopenia and osteopenia? So we know that with only one state as an exception, the prevalence of obesity is at least 20% or more. And this is also affecting the obese older adult population as well. And the baby boomers are becoming senior citizens. They're carrying with them the increased prevalence of obesity. 1 out of 4 obese, 1 out of 4 geriatric person meets criteria for obesity. Well, obesity causes serious medical complications. It impairs quality of life, and it causes premature death, and probably because of coronary artery disease. And metabolic syndrome is a constellation of risk factors that increase the risk for death, and is comprised of abdominal obesity, insulin resistance, as we know, dyslipidemia, and hypertension. And indeed, the prevalence of metabolic syndrome rises progressively with aging, and probably because of increased fat accumulation or redistribution with aging. But the obese older adult has been shown to represent the worst of both worlds. Not only do they need a larger amount of muscle mass to carry their heavy body weight, but they have sarcopenia, loss of muscle mass and strength because of aging. So they can't adapt to higher body weight by producing more muscle. So it puts them in a compromised situation. And they have abdominal obesity as well, and this is characterized by a predominant accumulation of visceral fat, which we know is fat around the intestinal organs. And that could be considered an exacerbation of the aging process. Obesity is caused by long-term positive energy balance, and the components are thermal effect of feeding, resting, energy expenditure, the energy expenditure of physical activity, which is the most variable depending on whether you're a sedentary person or a physically active person. And all components of total energy expenditure decline with aging. So it's easy to gain weight as you grow older, unless you cut down on your caloric intake as well. And there are major declines in a number of anabolic hormones, as we know, the so-called somatopause, growth hormone decline, menopause, decline in DHA. It's not accompanied by decline in catabolic hormone cortisol, so you have a catabolic hormonal milieu which predisposes to obesity. It's important to maintain the ideal body mass index because we know that the relative risk for that is linear, starting at a BMI of 25 forwards. But the relative risk for that with aging declines associated with an increasing BMI. So unfortunately, this has been misinterpreted as meaning obesity is less harmful in the elderly, but actually the absolute mortality risk with obesity increases in the elderly. In a number of studies, both cross-sectional and longitudinal, have consistently demonstrated that there is a positive relationship between obesity and declining physical function in older adults. And a BMI of 30 has been shown to increase the risk for later admission to the nursing home. So we first demonstrated in 2004 that obese people can be frail. We usually thought as frailty is muscle wasting, but we found More than 90% were obese, and in fact, they had relative sarcopenia, poor muscle quality, and decreased quality of life. And at the same time, Linda Fried's group, using the more popular criteria of weakness, slowness, weight loss, low physical activity, and exhaustion, found that obesity was associated with a 4-fold increased risk for frailty. In their study, if you have a BMI of 30 or more, you have a great prevalence of being pre-frail or frail. We found that obese people had the highest amount of absolute muscle mass, but they have the lowest strength per muscle mass when you normalize that and determine their muscle quality. There's something going on with their muscle, and it's not giving the proportionate amount of strength. So is there any positive thing about being obese when you're elderly? Sure. This RIDE's data showing that greater body weight, greater bone mineral density. Greater body weight, lower risk for fractures. So it's protective against osteoporosis. So we sought out a pilot study to determine whether weight loss therapy is beneficial or is harmful in obese older adults. We know that it's an important cause of functional disability. However, weight loss could worsen frailty by accelerating the usual age-related loss of fat-free mass, which leads to sarcopenia and osteopenia respectively. Our objective was to examine the effects of 6 months diet-induced weight loss combined with exercise, hypothesizing that weight loss and exercise will improve physical function and ameliorate frailty without causing a decrease in lean body mass. So the treatment group were given a calorically deficit diet, which is balanced and had about 1 gram per kilogram body weight of protein. We gave a little calcium vitamin supplementation, and deficit was around 750 calories per day with a goal of 10% weight loss at 6 months. This was combined with weekly group behavioral lifestyle therapy to teach them how to practice healthy habits and prevent weight gain and promote that weight loss. They also did group exercise training sessions 3 times a week. This was supervised by a physical therapist, and it was combined, consisting of flexibility, endurance exercise, resistance exercise, and ended up with balance, and the intensity was moderate to vigorous. This shows the baseline data showing that they're elderly, 70 years old was the average age, and they were almost morbidly obese with a BMI of almost 40. Sometimes, in younger people that would meet criteria for bariatric surgery. What we found that we were successful in inducing weight loss in older obese adults, suggesting that it's never too late in life to lose weight. In fact, I look forward to the group therapy sessions, and they bonded with each other. And here we show that the weight loss was predominantly fat mass loss, and there was no significant decrease in fat-free mass relative to the control who didn't lose weight. The lifestyle intervention ameliorated parameters of frailty, but objective indices, the physical performance test, aerobic capacity were improved significantly relative to the control, and this was accompanied by a subjective feeling of better function based on the functional status questionnaire. It improved parameters of upper and lower extremity muscle strength, improved their quality of life across the board, decreased almost all components of the metabolic syndrome simultaneously, resulting in approximately 60% prevalence of the metabolic syndrome. It decreased the concentration of inflammatory markers in the circulation, CRP and interleukin-6. Not all obese people develop diabetes because the pancreas are able to compensate by secreting more insulin. So it's important to see if the weight loss therapy improved the insulin secretion. And these data show that indeed the overall disposition index normalizes the insulin secretion for the prevailing state of insulin resistance. And this was primarily accounted for an increase in the static disposition index, which is an index in response to a given glucose level. But this was what we were afraid of. Diet and exercise therapy decreased bone mineral density and increased markers of bone turnover. Now, the bone loss was about 3% in the hip, which is an area that is a major concern, and this probably was not explained by DEXA artifact, because Here, it's accompanied by almost a tenfold increase in markers of bone resorption, C-telopeptide, and markers of bone formation, osteocalcin. So in 2005, the Obesity Society and American Society of Nutrition brought out a joint position statement with regards to future research directions. Long-term randomized controlled trials are needed in older persons to determine the clinical effectiveness, weight loss effectiveness, and safety of weight loss therapy. What is the best therapeutic approach for losing body fat while retaining muscle and bone mass? And our previous study was a combined diet and exercise intervention. We don't know which one was doing the effect. So the independent additive effects of weight loss and exercise was also important to determine on clinical outcomes, because not all obese people can lose weight by diet, not all people can do exercise, and not all people can do both. So we sought out to test the hypothesis that weight loss will improve physical function and quality of life, and that the addition of exercise will not only augment improvement in these outcomes, but also attenuate the adverse effects of weight loss and muscle mass and bone mass. And we reported the results in the New England Journal of Medicine last year, and we reported the bone data in the Journal of Bone Mineral Research late last year. I'm going to show you the data. So they were obese and elderly. Body mass index was at least 30. Age was at least 65 years old, and they could be older. They were sedentary, had stable body weight. They were on stable medications. No one had any severe cardiopulmonary disease that would contraindicate exercise training. And each one had to have evidence of physical frailty based on a physical performance test score of 18 to 32, the mild to moderate, excluded the severe frailty. Their VO2 peak based on the exercise stress test should be 11 to 18, and they also would have difficulty or need assistance in one basic or two instrumental activities of daily living. The outcomes primary was measures of frailty. We also look at specific physical functions. We look at strength. We look at gait speed. We look at static balance based on the one-leg stance, dynamic balance based on the obstacle course, and we measure body composition by DEXA and MRI, and we measured health-related quality of life. The participants that were eligible were randomized to either one of four groups: control group, no intervention; a diet group without exercise, an exercise group without diet, and a combined diet and exercise group. So we could isolate the independent effects of diet and exercise and compare that to the combined effects. We assessed 234 for eligibility, 107 were randomized into one of the four groups, and there were 14 dropouts over the 1-year period, and the analysis was intention to treat. This shows the baseline characteristics, similar to the pilot data. The age is 70 years old, and they had class 2 obesity, a BMI of 37. Attendance was relatively good, about 80% in both the diet sessions, the exercise session. We had no adverse effects on biochemistries. One participant fell during the physical function testing, which resulted in a fracture, so that was an SAE. We measured their body weight weekly during the first 6 months, and then every 2 weeks thereafter, except the control, who were assessed monthly. And this shows their weight over the 1-year period. Control and exercise did not have any significant weight loss, whereas diet and diet plus exercise were equivalent in inducing 10% weight loss at 6 months, and it was also effective in maintaining that weight loss over the next 6 months. So it's easier to lose weight, much more difficult to maintain that weight loss, and they were able to maintain weight loss, was encouraging up to 1 year, but exercise did not add any more further weight loss. And this shows the changes in the objective and subjective measures of frailty during the 1-year period. As you can see here, there's an improvement in physical function, in aerobic capacity, or objective measures, and an improvement in the subjective assessment of ability to function. Diet alone and exercise alone were all effective by itself, but the greatest improvement in physical function was when you combine diet with exercise together. And here are the specific physical functions. Diet in the diet exercise group had equivalent increase in muscle strength while the combined diet and exercise group tended to have the greatest improvement in static balance, dynamic balance, as well as gait speed. And there were significant improvements in the physical subcomponent of the SF-36 questionnaire in all the treatment groups. So this is one participant that was sort of an outlier because she lost about 20% of her weight, or about 20 kilograms. I just want to illustrate to you that it didn't necessarily do any harm. This is the same participant. Magnification is the same, so everything is smaller after 1 year. There's some wrinkling of the skin. And this is the MRI. After 1 year, there's 30% loss of fat. There's 10% loss of lean body mass. So that's what you expect. 25% of weight loss is lean body mass loss. And at the whole body level, assessed by DEXA, there was about 15 kilograms loss of fat, 5 kilograms loss of lean body mass. But what's important is the relative lean, or relative sarcopenia, when you normalize that lean to the total body weight, significantly improved because there were more loss of fat than loss of lean. And from 49%, that became 55%. Patient was frail at baseline, PPD of 30, was no longer frail at the end of the study. This participant got randomized to the diet and exercise group, which is what we want, and patient lost about 10% of weight at 11 kilograms. And at the Thai MRI level, he lost 18% of fat, but because of the exercise component, had no significant loss in lean body mass and probably had a modest increase. And at the DEXA level, there was 12 kilograms of fat, but there was no loss of lean body mass. So this is the ideal situation, losing fat and preserving that lean body mass by means of exercise. And even you don't have any loss of lean body mass, but the ratio of the lean body mass to the body weight significantly improved from 54% to 60%. And similar thing happened. This patient was extremely frail with a PPT score of 25, resulting in a physical performance test score almost perfect, 35 at the end of the study. This summarizes the changes in body composition in the 4 groups. So this is a diet, and diet exercise grew about 10 kilograms loss of body weight, and most of that body weight was lost of fat mass, equivalent between the diet and diet exercise group. But you can see here divergent changes in the fat-free mass. So the diet group without exercise lost about 3 kilograms of lean body mass. The exercise group gained about 1.3 kilograms of lean body mass. In the diet and exercise group had less loss of lean body mass as compared to the diet alone. So we're not able to prevent that loss of lean body mass, but we're able to attenuate it by adding exercise. But as you can see here, the change in strength was equivalent despite the opposite changes in lean body mass. You still get a 40% strength. And this diet group that lost about 3 kilograms of lean body mass had no change in strength. So that demonstrates an improvement in muscle qualities. Probably there could be several reasons. One of those could be decreased fat infiltration or decreased cytokines in the muscle. So looking at the mechanisms, we infused stable isotopes, measured a fractional synthetic rate of muscle protein synthesis during the post-absorptive basal state and the fed state, did the muscle biopsies, and we show that indeed the exercise training improved FSR during the fasted and fed state, so it was universally effective. In looking at the other aspect of the protein turnover using whole body whole body protein turnover, there was a decrease in the rate of appearance of leucine in the blood, suggesting that there was suppression of whole body protein breakdown in response to exercise. So there's an improvement in muscle protein cells and a decrease in whole body protein breakdown, with a limitation that this examines not only muscle but the entire whole body. And we look at the expression of the inflammatory genes in the skeletal muscle. We compared diet alone and exercise alone directly, and what we found was only the exercise reduced the expression of interleukin-6 and tumor necrosis factor, and increased the expression of mechanogrowth factor, which is an isoform of IGF-1. whereas diet had no effect. So this is not reflected in circulation. You won't be able to know that because there was, when you have a combined intervention, all of those decrease, but in fact, it's probably only as a result of the exercise, and diet did not have any effect. And we look at the changes in the intramuscular fat using MR spectroscopy. Here in the gastrocnemius, it appears that there is a decrease in intramuscular fat. You do it in the cellulose, which is the type 1 slow, the type 1 slow twitch, and there's an increase in intramuscular fat. So it depends on what muscle you look at, and we look at fat in the liver as well here with MR spectroscopy, and show that it significantly decreased about 40% to 50% in both groups, and this was inversely related to the improvement in insulin sensitivity. So what about the changes in bone mineral density during this 1-year intervention? So what we found is that diet, of course, decreased the bone mineral density by about 2 to 3%. Were at the total hip, at the femoral neck, and the trochanter. And exercise had the opposite effect. It increased bone mineral density by about 1 to 1.5%. But when you combine exercise with diet, it did attenuate the weight loss-induced reduction in bone mineral density, such that there was no significant decrease in bone mineral density from baseline. It was comparable to the control. And in terms of markers of bone turnover, you see the opposite effect. Diet increases the rate of bone resorption, as well as the rate of bone formation, and exercise does the opposite. It suppresses the rate of bone turnover, and when you combine exercise with diet, you shut down that increase in rate bone turnover that's induced by weight loss alone. So it's able to prevent that expected increase in bone turnover in response to weight loss alone. And this summarizes the bone mineral densities across the 4 groups. Similar to what happened with the lean body mass, diet decreased it by 2%, exercise increased it by about 1.5%, and you have an attenuation of the diet-induced loss of bone mineral density when you combine it with exercise. So instead of losing 2%, you lose only 1.1%, but you still have an absolute loss of bone mineral density. So this shows that the diet and the diet exercise group, as a result of the weight loss, the fat loss, decreased their leptin, and they decreased their estradiol. But despite the decrease in these bone-active hormones in the diet and exercise group, it was able to prevent a loss of bone mineral density. And in fact, these changes in these bone-active hormones are not correlated with the changes in bone mineral density. So when we did a stepwise multiple regression analysis of the variables affecting changes in bone mineral density, what we found was only change in lean body mass, change in serum osteocalcin, a change in 1 repetition strength were independent predictors of the changes in hip bone mineral density, whereas changes in leptin, estradiol will knock off from the model, so they were not important. So sclerostin is a protein, as we know, produced by the osteocyte. When you have unloading, the osteocyte secretes sclerostin, and this results in decreased bone formation, and loading decreased sclerostin production. And what we found that was weight loss alone increased sclerostin, but when you combine that with exercise, the increase in sclerostin in response to diet-induced weight loss was totally prevented. We also look at indirect measures of bone quality here using the hip structure analysis of back. So what do we expect for effective treatments? Cross-sectional area should increase to reduce axial stress. Section modulus should increase to reduce bending stress. And buckling ratio should decrease to reduce susceptibility to buckling. And indeed what we found was diet had adverse effects on hip geometry, as you can see here, across all the sides, narrow neck, intertrochanter, and femoral neck. There was a decrease in cross-sectional area, a decrease in cortical thickness, and an increase in buckling ratio. They're all bad. But when you combine that with exercise and you prevent this adverse effects on hip geometry induced when you do diet-induced weight loss alone without exercise. So I'm going to switch gears a little bit. So is low bone mineral density associated with weight loss necessarily associated with increased rate of fracture? And people practice caloric restriction to look good like this, but there is a group of people who are practicing long-term caloric restriction because they want to live longer and healthier life. And they're members of this caloric restriction optical nutrition society, and they come to our center. They just want to be evaluated to prove their hypothesis. Okay, and they think they're normal and we are abnormal. So you got to be careful when you compare the bone mineral density and say the bone mineral density is low compared to the normal, and they won't like that because it's debatable who are normal. So caloric restriction has powerful effects against cardiovascular disease. However, low bone mineral density in people on long-term caloric restriction diet, they have not had any fractures. They have low levels of inflammation because of low fat, normal vitamin D status, and low bone turnover. So we wonder whether they're protected from fractures because of good bone quality. Specifically, despite a low BMD, they have preservation of trabecular microarchitecture as evaluated micro-MRI. And thus, caloric restriction represents a unique coexistence of low bone mineral density and good bone quality. So as we know, the two people can have the same amount of bone volume, but the other one could have poor bone quality because of perforations of the trabeculae, as you can see there on the left side. And we use a micro-MRI product which has components of the pulse sequence software, the imaging coil, you put in on the wrist, and there's a proprietary software algorithm. This company is already closed, but we were fortunate enough to collaborate with them, with Mike Cooper, and using Felix Swirly's technique. And this shows the hypothesized structure of the bone, and you have the 3D rendition of the trabecular core, and this is the cubic subregion, and this is the skeletal representation with topological assignment based on color coding as above. So this one, for example, would be considered curve-to-curve junction, the orange one, and this green one would be the curve interior. So the micro-MRI has been shown to be more sensitive as compared to DEXA in discriminating people with fracture versus no fracture. As you can see here, there was no difference in bone mineral density between these two groups of people if you use DEXA. But then if you use the parameters of micro-MRI, bone volume over total volume, trabecular thickness, plate rod ratio, erosion index, there are statistically significant differences in these parameters. So we reported this in Aging Cell, and forgive the very long title, I'm just going to read it to you. Reduced bone mineral density is not associated with significantly reduced bone quality in men and women practicing long-term caloric restriction with adequate nutrition. So what we did in here was we compared people that are members of the Crohn's Society and people practicing Western diet, and their age match. And as we expect, CR group have lower body weight, lower fat mass, lower lean body mass, and accompanying that lower body weight is their lower bone mineral density across all sites. But despite the lower bone mineral density, people in the CR group don't have an increase in rate of bone turnover. It's similar to the Western diet group, as you can see here, based on CTX and bone-specific alkaline phosphatase. And more importantly, they have significantly low levels of inflammation. And caloric restriction suppresses inflammation. That's believed to be one of the mechanisms that extends lifespan. So here we use CRP, and the difference is statistically significant. And this just shows that they're really caloric restricted, and we did food questionnaires. And they're not vitamin D deficient. In fact, they are overeating vitamin D, supplementing themselves with all these vitamins. And here in a subgroup of these people, about 10 of them, we did a bone mineral density and compared them directly, and they're all significantly decreased and compared to the Western diet group. But as I mentioned to you, the micro-MRI is more sensitive than the DEXA in discriminating people that are at risk of fractures than those who are not. So when we do micro-MRI, we would have expected that their micro-MRI parameters would be significantly worse compared to the people eating typical Western diet. And what we found out that There were no differences. Despite their significantly low bone mineral density, the parameters of microarchitecture, bone volume, trabecular thickness, skeleton density, surface to curve ratio, erosion index were not different from people eating typical Western diet. So suggesting that they may be protected against fractures because of low inflammation, and they have good bone microarchitecture despite significantly low bone mineral density. Limitation of the study, of course, this is cross-sectional. It needs to be documented further or proven with longitudinal intervention. And a summary, successful weight loss is feasible in frail, obese, older adults. The addition of exercise to weight loss does not prevent, but it does attenuate weight loss-induced decrease in lean body mass. Weight loss alone or exercise alone improves physical function and ameliorates frailty in obese older adults. However, the combined weight loss and regular exercise may provide greater improvement in physical function than either intervention alone. A weight loss therapy might decrease bone mineral density, and the clinical significance of this needs to be determined, whether it increase the risk of fractures. And Tammy is very interested to collaborate, and we're going to measure QCT. And further studies are needed to determine whether weight loss can be maintained more than 1 year and prevent institutionalization of obese older adults. It doesn't matter if they lose weight, but they regain their weight back, then it's a non-issue. We've got to demonstrate that they have sustained weight loss and sustained physical function. And we're able to ask some of these people to come back after a period of 30 months, and we can see there's a little bit of weight gain, but it's encouraging because they still had 8% weight loss relative to baseline, so suggesting that older people may be more compliant and more and may be able to maintain that long-term weight loss and physical function. And thank you, and the studies were supported by National Institute of Aging.
So let's simultaneously open the floor for questions for Dennis, and then the other speakers come up to the stage for the panel discussion on all that.
Mark Fabreo, Melbourne. Dennis, it was really interesting, your last slide, that you don't get the rebound after 30 months in older adults, because most studies in younger obese adults, in intervention studies, it's usually there's regain by 48 months. So my question is, did you examine some of the hormones that are released from the gut and from the adipose tissue that regulate satiety in the older adults? For example, GLP-1 or CCK or leptin, and did you look at those hormones pre and post exercise and diet intervention?
We didn't, but we have remaining plasma. Well, we're not funded to do that, but we did measure leptin. I think I showed some leptin data, but not those ghrelin and other things. Be interesting to measure, and if you want to help with funding that one. Thank you.
Wayne Carter, Kansas City Area Life Science Institute. I had a question on your methodology. On your MR spectroscopy, were you basically using a fat sat and a non-fat sat sequence and subtracting the two to measure fat in the muscle, or what were you actually measuring with the MRS?
Yeah. You know, this was a sub-study of one of my postdoc fellows, and I believe that was the procedure, but you know, that's not my area. I just presented the data to show you the findings, and we have not published that.
And one of the reasons I ask is because there oftentimes is this question. Obviously, when you lose weight, you're losing, or when you gain weight, there is muscle, there's fat which is present within the between the muscle fibers and so forth. And DEXA isn't able to measure that. And so one of my questions is, did you actually, because you've got MR and DEXA images, have you actually gone back using that MRS to try to understand the error that we get when you rely on DEXA to measure lean muscle mass as opposed to using MR, where you can more accurately assess how much fat is intercalating between the muscle fiber?
We have not done that. Thank you.
Yep.
I had a question for you. The 30-month follow-up, you mentioned that some of the people came back for the 30-month. I was wondering how many and whether you think there's a selection bias there, only those who were still thinner really came back.
That's a possibility, and we did not plan to ask them to come back, so they were sort of surprised. And we wanted it to be just one visit. And I had one of my postdoc fellows take charge of that as his project, and I was looking at, because I just reviewed that data, and I couldn't see any particular reason with regards to weight. There were probably a few people. This is just a subgroup. We just asked to follow up the first 2 cohorts as finished, because the other cohorts were still not 2 years in the study. And there were reasons given like, they've moved on or they were busy with their work, and one person had said that she was sick. So that was a not a significant portion, but we can only speculate maybe they didn't want to come. But it was encouraging because it was almost like 80% had come back. And I gave you the average, but there was a wide range of that. 8% weight loss, but some had gained weight and some had lost weight. But the average was about 8%. But I wish I could give you the individual time point. That was just kind of messy.
Hi, I'm Delphine Morel from the lab of oral biology in Kansas City. You showed that there was a loss of BMD compared to your control group, but your control group were obese people that didn't train or didn't follow a diet. Am I right?
I'm sorry, there was a loss of bone mineral density.
Compared to your control group?
Yes.
Which are obese people. So do you have an idea of how the BMD is compared to people with a normal weight?
Yeah, so the T-scores, most of the T-scores were normal. So none met criteria for osteoporosis. So this modest bone loss of 2%, then bring them down to the osteoporotic level of a T-score, if that's what you're asking.
Yeah, because usually people that are obese or overweight have a BMD that is higher than people with normal weight. So maybe the BMD is decreased, but it's still the same, like not significantly different compared to people with a normal weight. Yeah,
you're right. So it was still high relative to the normal, but they did have an absolute loss of bone mineral density. But there's some, articles citing that, obesity might have poor bone quality. So we don't know what this effect on bone mineral density or bone quality may have in the long run. So we'll be very cautious with that.
My other question was, what do you mean by Western diet?
We're eating Western diet. If you're
in
not
America or?
America, yeah. Caloric restriction, if you're caloric restricted, you're eating Western diet. So the usual diet.
Okay.
Does that make sense?
So I had an observation and a question. I believe in the DPP, the Diabetes Prevention Program, that the older people enrolled in that study actually did better with the diet intervention. They were more compliant and lost more weight than the younger women, and actually had a lower response to the metformin. So I think that that older people can become involved in trials and lose weight is entirely consistent with everything we know about physiology. I think that there is one thing that kind of sticks in the back of my mind and bothers me a little bit, which is Susan Roberts did some studies years ago and repeated them that showed that older people who lost weight, for some reason it took them many more months to regain than a group of normal, healthy younger people. And the same thing, if she overfed them, they also seemed to lose their set point, and it took them much longer, if ever, for them to come back to their baseline weight. And in the back of my mind, when you say that older people keep the weight off, there is a little bit of an alarm going off, wondering whether the fact that people keep the weight off is good or bad. And I think that we need studies that do long-term follow-up, as the DPP is doing and as Look Ahead will do, to identify whether there are any poor effects of weight loss. I don't expect that there will be, but the study of Susan Roberts is very provocative and raises that question.
I just want to comment that these people love the socialization. They bond with each other. Most of them are retired, and we recruit them for the study. In fact, they purposely retire so they could join the study. And after the study, they're upset, and you know, their relatives or their daughters want them to miss study. And I had one participant who was bereaving, just lost his wife, and he was over the study. After 1 year, the daughter was very upset that, you know. So the bottom line is improving quality of life, making them happy, and they're very, very proud of their achievement, and they're very willing to be advocates of our study. And again, in geriatrics, it's quality of life. Not necessarily to prolong life, but to add life to years. So as long as they're happy, and we're happy too.